this week on the BackTable podcast.
We need to join forces and work together as teams. Why are we putting the patient at risk just because of money? And we think our system is better, when clearly, if we work together, we're going to have the best outcomes overall, right? High tide floats all boats. So I think we really have to do that versus this siloing mentality that, no, we're the best, we have the best local control, it's minimally invasive. But unfortunately, they don't have a lot of data comparing what they do head to head with us. There's no randomized data. There really isn't.
I'm Kavi Krishnasamy. I'm an interventional radiologist, interventional oncologist at UAB Birmingham. I have Damian Dupuy, who is really a legend in the bone ablation space, having done and performed bone ablations far before many of us were aware that this was a appropriate and optimal therapy. So, Damian, thank you for being here. This is, again, a real treat for me. Really looking forward to chatting with you. Why don't you introduce yourself and tell us a little bit about your practice?
Thanks, Kavi, and thanks to the BackTable for the invitation. It's a real honor. So, I've been doing bone ablation since 1993, where it all started at Mass General. And I went to Brown about 4 years later, just when the devices were getting FDA approved. And I was there for 20 years, kind of broadening the scope of image-guided tumor ablation. Ran a couple big NCI-funded multi-center trials. The first one was on bone ablation and pain palliation, and we'll talk a little bit about that later. I'm still involved with research at Brown, but I now work at Cape Cod Healthcare, and it allows me to basically take care of a large population with lots of cancer. So it's very helpful, and it's where I grew up, actually. So I'm giving back to my community.
Super cool. How did you get involved with bone ablation? Where did it start?
So Dan Rosenthal was my mentor. He was the section chief in musculoskeletal radiology at MGH. And I started there as junior faculty, and he was doing osteoid osteoma treatment of children. As you know, osteoid osteomas are roughly a centimeter in size, very painful. Previously, they were treated with surgery, and Dan happened to see a neurosurgeon put an RF electrode through the foramen ovale to treat trigeminal neuralgia. And he had asked this guy, Bill Sweet, how big of an ablation can you get with that? And he said, about 1 centimeter. And then he scratched his head and he goes, maybe we could do this for osteoid osteoma. And lo and behold, they did an animal model in dogs with the cardiologist's help and showed that you got a 1 centimeter ablation with this particular probe that was used for trigeminal neuralgia. And then they did a clinical trial in patients, and that's right when I started on staff. So I got to see some of the early bone ablations with a non-cooled RF electrode. It was really cool.
Wow. Okay. And so historically, what did we have when kind of bone ablation took off? Was it just RF? Was it more conventional?
Okay. It was just RF. And Nahum Goldberg was my resident, and he actually watched one of these cases, and he was just taken aback, saying, this is amazing. And what if we could create larger tumors, So Dan said, well, why don't you work with Radionics? It's a company that was founded by MIT PhDs, and they were close by. So Nahum helped develop the cool tip with Radionics based on a patent that was done, I believe, in Denmark, where if you cool the tip of an RF needle, you reduce charring around the tip. And that helps the transmission of the electrical current in the transverse diameter, so you can get a larger ablation compared to with a non-cooled needle. And that's where we kind of got started. And I had a prototype needle, which we put in a patient who came up from Providence with metastatic gastric cancer to the iliac crest. And we put one of these cool tip ablations in, and we got a 4 centimeter ablation. And we were off to the races at that point.
That's amazing.
So it was kind of fast and furious there.
Well, and I think a large part of the U.S. really doesn't use RF anymore, but it's still very widely used in the bone space specifically, and then worldwide because of availability and cost, right? As you know. So that older generation, I mean, the cool tip was eventually became Covidien, and then it became Medtronic, right? And I've used the cool tip as well, which was a great device for its time, but it was a unipolar device. So you still had to put grounding pads on. And what's available in the RF bone space outside of our traditional bony needles now?
Sure. Well, you have the bipolar system from Medtronic, which is a kind of a low power system, and you can put in 2 electrodes. And that's primarily used in the spine, although you can use it in extraspinal locations. But it's really kind of underpowered. It's less powered than the cool tip. The cool tip is about a 200-watt generator. But more exciting news is that the grandson of the guy who invented the original RF electrode has a new company. They've been out maybe 4 years, called Cambridge Interventional. And they have a 380-watt generator.
Wow. Okay.
Which I've been using for about 4 years. And I'll be honest with you, because the tip is very sharp, it's low metal, so less artifact, and you can measure a temperature at the tip, it's kind of a game changer for me, because you can sculpt lesions thermally and really understand what's dead and what isn't with a simple needle, 17 gauge. So I've been using that for most of my cases. So I've kind of switched. I was doing a lot of microwave, and now I'm doing mostly RF.
In the bone specifically, or everywhere?
Everywhere.
Everywhere. Wow. Okay.
Everywhere.
All right. That's pretty amazing. I don't know much about that system. I'm going to have to kind of delve into it a little bit, but very exciting. So then tell me, where did other therapies, cryo and microwave, when did they come into the fold? Obviously, RF was kind of the initial jump into this space for interventional radiology, but when did all that happen?
In the early 2000s, we had a percutaneous cryoprobe that came to the market, and we started using that mostly in soft tissue, but we also started to do it in painful bone tumors. And we liked it for the superficial location and the chest wall. So that kind of took off a little bit. We weren't using it in liver, although some people were using it in liver, mostly in soft tissue and bone. Then microwave came out a little bit later. That was maybe a couple of years later. And that was the 915 system that came out of California. And initially it was used for breast. And then Covidien ended up buying it. And because they saw that their cool tip sales were going down, specifically in my lab, because I was using more microwave. And that was a 3-channel system, but you had to have 3 separate generators, and you have to press the on button at the same time. So that was a little bit cumbersome, but you can get pretty good size ablations. Covidien then decided they wanted to create their own microwave system, which became Evident, which was still 915. And then they took that platform and threw it away and started Imprint, which was the 2450 single needle, which they still have today.
Yeah, the space has changed so much in the last 10 to 15 years. I was a longtime New Wave user, and obviously we know that New Wave is not with J&J anymore. So the space continues to evolve, and new devices come, and we continue to drive data. So that's very, very cool. And this has been a long time passion for you. You've published, you've led multiple prospective clinical trials. Let's talk a little bit about some of that work, if you're okay with it. And some of the, aside from just the outcomes, some of the metrics that you kind of describe that showcase efficacy, right? And so I'm looking at the Gwinnett et al. Article in 2013 that you were a part of, and this concept of bone-tumor interface. What is bone-tumor interface?
Sure. Well, whenever you have metastatic disease to the bone, the part where the bone, the endosteum meets the tumor is the bone-tumor interface. And that's kind of where all the pain emanates from the endosteal pressure of the tumor and the inflammatory parts of the tumor. And that's why radiation works for bone cancer pain, is because it kills some of the inflammatory cells, which are causing all the problems related to the resorption of bone. The bone-tumor interface was something that we described when we analyzed all of the patients that had painful bone tumors treated with RFA as part of a multi-center trial through the Akron organization. And we published that data. And after we published it, we analyzed the bone-tumor interface effect and efficacy. So all the cases that had ablation had follow-up contrast-enhanced imaging studies. So we were able to look at that and then determine how the morphology of the treatment, the anatomy of the treatment, and how it correlated with success in palliating those patients. And we found that the longer the bone-tumor interface was undergoing treatment for the ablation, the better the results. Which makes sense.
100%. Well, and I think I've made this mistake. Mistake is probably the wrong word, but I have done this many times in my past. And with the focus being on treating the entirety of the tumor, but in reality, you don't need to treat. These are palliative situations most often, right?
Correct.
And so treating the entirety of the tumor and then ablating into a adjacent critical structure is not the goal. To your point, it is what is the source of pain and ablating that area, which is the bone-tumor interface. So that's a great point. Was there anything else in those studies, and you've shared them with me previously, so thank you for doing that, that you definitely wanted to allude to from an outcome or specific metrics that led to better outcomes?
Yeah, you obviously want to stay away from major nerves, motor nerves, right? So, of course, those you have to be very, very careful with. And you might want to use a thermocouple to know exactly what the temperature is between your probe and that which you don't want to heat. And you can do that with RF. Obviously, with cryo, you can use the ice ball visualization to prevent over-freezing into a large motor nerve. And also, I do all my patients awake. I don't use general anesthesia, so I'm able to monitor motor function during the procedure.
Got it. Okay. Now, do you ever use any sort of nerve protection or nerve monitoring outside of just in real time with an awake patient?
So in children, I've had to treat some large recurrent sarcomas, particularly involving the pelvis, and I wrote a paper illustrating the use of somatosensory evoked potentials to determine that you're not damaging significant motor nerves. But that's quite an ordeal. And not everybody has the ability to use that in their institution.
Yeah, very good point. And specifically in those anesthetized patients, do you feel like that process works equally well for heat-based and cold-based solutions, RF versus cryo? You have some people in the community that talk about cryoablation zones getting away from you fairly quickly and growing into a nerve, even if you are monitoring evoked potentials. But I'm curious what your thoughts are there.
Well, again, the goal is to palliate the pain, right? So really focus on the bone-tumor interface and don't get away from yourself thinking that you're going to cure the tumor there. So choose your battles wisely.
Yeah, absolutely. That's a great point, and I think it's easy to forget that. How about patient selection? How are you choosing who to treat?
They basically have to be somebody that you think is going to live at least 6 months, right? If they're going to die within a month, it's probably not a great idea to put them through a big ablative procedure, because it's going to be tough to recover from that with a small amount of life left. So they have to pass the eye test in that regard. And then really it's where it is anatomically. Can you get to the bone tumor interface and treat it safely? And then the third thing, can you do it in combination? And we can talk about that with the upcoming trial that the SIO is sponsoring, doing radiation plus ablation to get better local control for some of these large metastatic lesions or oligonodular disease. So it's really the eye test, and you can look at images all you want, but meeting the patient and talking to them and determining what their quality of life is, and do they still feel like they have something to give and they want to be alive? A lot of times it's family and friends that are keeping them going, and sometimes they just say, I'm done, doc. My family's pushing me. I really don't want to go through this big procedure. Which is, it's fine. It's really a patient-driven decision.
Yeah, it's a great point. And even in my practice, that is the first conversation, and what the goals of the patient are. And let them guide my decision making in a way. And so important to have that clinical conversation with the patient. So great point. All right. So when you select a patient, what scoring systems are you tracking and using from preoperative or pre-interventional clinic visits to post-interventional follow-ups? Obviously, pain scores, I assume. Any functionality questionnaires, quality of life questionnaires? What are you looking at?
Well, when I was doing academic research, certainly collected all that data. But right now, it's we see patients in follow-up, and we make sure that we've had a positive response based on their activity of daily life and how they're feeling. But we don't necessarily record that. That's part of the chart when we go over it, but we don't record it in any other format other than a clinical note when we see them in follow-up.
Okay. So mostly pain score and just activities of daily living and things like that.
Correct.
I gotcha. Okay. That's fantastic. There's, as you said, there's such a wealth of information there. And I think even in the MSK embolization space, right, we're tracking a lot of data prospectively, but ultimately it's that pain and functionality and how the patient is tolerating everything. Obviously, I'm sure, you go after small lesions, you go after large lesions. Specific to those larger lesions, how are you approaching and treating? We talked about the bone-tumor interface, but how do you decide how many needles to use, where to place them, et cetera, et cetera?
Sure. Well, obviously, I try to use the most powerful cryoablation devices I can get, because then I have to use fewer needles. And I've been, pretty happy with the V-probe, which Varian I think has right now. It used to be just a straight probe and then a fixed probe, but the V-probe allows you to do 1, 2, 3, 4, or 5 along the length. Basically, it's an insulation that's retractable, so that you can basically change it during the case, before the case, whatever, which is nice. And I typically would use probably no more than 5 for a big tumor, because it just becomes too cumbersome to kind of dry those all at once and then reposition. It becomes much more complicated.
You're talking about cryo specifically, right?
Cryo specifically. Yeah. And, if you have a very large desmoid tumor, and I didn't really bring any desmoid tumors to this discussion, but, they tend to be very large when they're symptomatic, and they require multiple positions because they're usually in the shoulder girdle, and they're kind of funky anatomic areas that you have to be really careful. So you might choose to use some smaller probes along with larger probes simultaneously, again, to kind of sculpt the lesion. But I prefer to try to keep them as parallel as possible, just using the old adage that Peter Littrip always talks about, the 1-2 rule. So 1 centimeter from the margin, 2 centimeters from each other as far as the probes go. And if you use that, you're more likely to have lethal ice throughout your freeze zone. Not just monitoring the ice visualization, but really carefully placing the needles so that you can achieve that. The nice thing with RF is you can measure the lethal temperature, because the tip of the needle is actually a thermocouple. So you're cooling during the actual heating, but if you want to interrogate the temperature, you shut off your cooling pump and then you watch the temperature rise. Once you get to 60 degrees Celsius, it's immediate cell death. Typically, I like to get above 20, so we get super, super hot areas. And then I move the probe into a location that's close, and I measure the temperature there. And if I'm well above 60, I move it a little bit further. And then I can determine exactly the lethal overlap, and I'm sculpting the lesion throughout. And it actually is quite fast. Most metastatic lesions heat up very, very quickly, much quicker than the liver, much quicker than kidney. And if they've been radiated, they're very hypovascular. They heat up even faster. So you can do an ablation in a given location for 3-4 minutes tops, and then you can move the electrode around and sculpt that. If you're using CT fluoroscopy, you actually can see the gas forming and the low density changes. And if you have any question, you can always do a verification CT with contrast at the end to make sure that you've got good coverage of the bone tumor interface.
That's a great point. So that's your kind of, I don't want to say obviate, but that's your workaround for an ablation confirmation, if you will, right?
Right.
And you're able to march the needle around either with the ultrasound or CT. and then verify whether you had a lethal ablation zone. And so again, your target temperature is 60 degrees Celsius, correct?
That would be immediate cell death. I'm usually 70.
Okay.
70.
Okay. So you're targeting 70 degrees as you're moving your needle around and then sculpting the ablation zone. And obviously, go ahead, sorry.
And what's interesting is, people in the old days sometimes would use only impedance-based, right? And if they impeded out a few times, then they were done. You can get to 70 degrees with like half the time of that. So we're actually over-treating if we were just going by algorithms. But if you just go by what's happening in the tissue in front of you, you can really march through it much quicker.
Yeah, okay. That's a great point. I find myself, especially for larger lesions, moving a little bit more towards cryo just for visualization of the treatment zone, understanding completely that edge of the ice ball is at 0 degrees and it's not lethal, right? But just to give me a little bit more visualization. But your point is very valid, and it's a great way to kind of sculpt a lesion or sculpt an ablation zone in a lesion. That's pretty cool.
And if you're going to do strengthening at the same time, it's much better to have a heat base because you contract the tissue, creating better space to accept your glue, and you don't have to wait forever for the thaw. And a lot of people bring them back the next day if they cryo and they want to do cementoplasty, but this time you do it right afterwards. So
yeah, that's a great point. What about with these large soft tissue lesions as well with cryo or RF? We talked a little bit earlier before the podcast about cryomyositis and myoglobinuria and things like that. Do you worry about things like that? Have you seen issues on the cryo side specifically from those large ablation zones?
Well, if you're going to treat something that's over 4 centimeters, it's probably a good idea to alkalinize the urine by giving an amp of bicarb and a liter of saline. And what that will do is that'll keep the kidney flushed and preventing the deposition in the kidney, which can lead to renal problems. So that's number one. And you don't necessarily have to measure the pH of the urine after to do it. I just empirically do that. Amp of bicarb and a liter of saline. You infuse it right before the procedure, and then you just continue with normal saline in the recovery area. You want to keep the urine from being like maple syrup, right? You want to keep it as clean as you can.
Now, and that's the myoglobinuria, correct?
That's the myoglobinuria. Now, as far as the, over treatment of muscle, that's a potential collateral damage, right? If you're heating or cooling too far into a muscle, you're obviously going to have increased pain and the recovery time is going to be affected. So you have to be careful of collateral injury because you're going to take an outpatient procedure and potentially make it an inpatient procedure. And then you're saying, well, normally my patients get better in a couple days or a couple weeks. Well, it's going to be longer than that if you have a big area of muscle kill.
Yeah, that's a great point. I think early in my practice, this concept of cryomyositis, which just was from over-treating in a palliative setting, as we already alluded to and talked to, it taught me very early that if I'm not careful, then that patient gets an overnight admission with more pain than they came in with, and in need of pain medication and steroids and things like that to allow for kind of amelioration of that acute inflammation. Back to the myoglobinuria, are you seeing that with cryo and heat-based therapies, or only one or the other?
It's interesting. If you measure myoglobin in patients who get large liver ablations with microwave, you will see an elevation, no question about it. But it tends not to be as problematic as it is with cryo. You get the so-called cryo shock and myoglobinuria. So you have to be more careful with cryo because I think the elements that get released are more available than the denatured protein and heat sink scar that you get. You just have to be careful. Just keep that urine clean.
Great point. So when you see these large tumors in clinic, what do you tell the patients, right? I mean, I don't want to speak for you, but I find in my practice, I try not to promise a full pain relief, and I more speak to 50% reduction in symptoms and better quality of life and functionality. But what do you say to them?
Well, that's a really good point. I say that my job is to reduce your pain and not hurt you. So if it's a single lesion and then you have no other metastatic disease, you could say, well, this is the only area that we see. I can choose an aggressive route where I'm going to try to kill the whole thing in one shot. But I say the chance of that happening is maybe 50 to 75%. Or we can use a combination treatment where I kind of kill the orange And then we bring radiation in a few weeks later when you have the healing effect and the hyperemia from the reparative phenomena that occurs around the ablation zone. That oxygen-rich environment is much better at killing cancer with radiation because the oxygen level is much higher. And you need oxygen to create the superoxide anion, which creates a mutation in the programmed cell death. So I always recommend, if we're going to do combo in a big tumor, ablate first and do radiation second.
I gotcha. And when you speak just towards pain relief in the palliative patient, what do you tell the patient? 50% reduction, or you try to stay away from that conversation? And
I try not to use percentages. I said my goal is to reduce the tumor that's causing the pain, and I don't want to create more pain from the procedure. So I would say that 75% of the time we help patients with large tumors, but it's not close to what we do when you say you're treating a 2-3 centimeter tumor on a rib. Those are much easier to take care of.
Of course. And you've shown that in a lot of your prospective work as well. I think the challenge is sometimes, when you have a patient that's expecting their pain to be gone, if we don't set those expectations or the appropriate expectations ahead of time, sometimes they're dissatisfied even though they're actually quite a bit better, right? And so that's part of that conversation that we need to have. I know you mentioned predominantly using sedation for your therapies. Outside of pediatric patients, are you ever using MAC or general anesthesia, or just local for that matter for some of the smaller lesions?
Sure. Well, for general anesthesia cases, obviously pediatrics. So if I'm doing an osteosarcoma or I'm doing a cancer in a child, I'm going to use general anesthesia. If it's going to be a very long case, like a cryoablation of a desmoid tumor that's 6 centimeters, the patient's going to be in an uncomfortable position for quite some time, I'm going to use general anesthesia for that. Some patients request general anesthesia. I try to talk them out of it if I think it's not necessary, but occasionally we'll do that because of patient preference. I don't have a problem with that. It just means that I'm doing a case later in the day because we're like third in the list when it comes to general anesthesia. You have cardiac synchronization, you have a C-section, and then you have the cath lab, and then you have the RF lab. So I like to do my cases in the morning. That way I can recover my patients. And, it's really an outpatient biopsy and ablation for most of my cases. So as far as sedation, when I do my cases with sedation, I use lorazepam intravenously, and I usually start with a milligram, and then I'll go a full milligram when they're in the room. I play the music of the patient's choice, and I use intradermal lidocaine and bupivacaine, and I used that to block the tissue that I'm going to be treating next to. And most of the time, I only have to use maybe 25 mics of fentanyl and 0.5 of Versed, and that's it.
Wow. Okay.
So these are older patients typically, and then their recovery is much better. So they're not sleeping for 6 hours after the case.
And this is cryo and heat-based therapies, or just one or the other?
Yeah.
Wow.
And,
Okay.
I did a cryoablation of a breast cancer, and the patient wanted to be awake for the whole procedure. So I did nothing other than local, and she watched the whole procedure. So she was kind of fascinated by it. So
Wow. Okay.
So you can get by, I think we over-sedate patients. I think if you're using blocking agents, that's really all you need with some lorazepam.
Yeah. Okay. That's a great point. It's interesting that you bring that up. I had a similar experience with the GAE recently, and the gentleman was on the table and watching the screen as we were watching the screen and cathing and embolizing and all of those things and asking questions in real time, which was really funny.
Yeah.
So, okay, I want to switch gears a little bit. What about, and we kind of touched on this a little bit, oligomets for curative intent, or the oligoprogression type scenario for disease control. Let's say you have a patient with RCC and an L5, a iliac wing, and a rib lesion. Are you going to go after all of them with curative intent?
Well, it would depend on the size, obviously. And also it would depend on whether they're a candidate for systemic therapy. Because with RCC, immunotherapy works pretty well. And there are also small molecules that work pretty well. So you might do what you think is curative intent, but make sure that they go on systemic therapy. So it's kind of a 1-2 punch. And if you're going to do the ablation and they're going to have immunotherapy, I usually give the immunotherapy first, and then 2 weeks later, I do my ablation. That way the immune system is primed so that when you release antigen from your ablation procedure, it's more likely going to stimulate the immune system. So you want to be at the peak of listening, and then the antigen floats by and it picks it up, and hopefully you get a systemic response. That's the goal, right? But I think for tumors, 3 centimeters and smaller, it's reasonable to be able to kill them completely as long as they're not sitting on a nerve or up against a big blood vessel.
Yeah, absolutely. Great point. And then you mentioned combining with systemic. I think that's a fantastic point. We're doing that really all over the body. So obviously, I think it makes a lot of sense to do that with bony ablation as well. I haven't seen a tremendous amount of data there, though, unfortunately, but hopefully we will have some, coming in the near future. How about the oligoprogressive situation? Are you seeing patients where, I don't know, they have 8 lesions as an example, and one of them is a little bit out of control, and then you're targeting that one?
Yeah, I mean, that is actually becoming an increasing part of my practice because we're doing more biopsies of these patients, doing next generation sequencing to find another target. And oftentimes they're finding a target and they're going on a different agent, which works pretty well, except that you have a couple of recalcitrant areas and they come back to you and they say, can you treat those? And then can you do a biopsy at the same time? And you're like, oh, of course, right? If I'm going to have my needle there, I might as well biopsy it and ablate it at the same time. So they're happy, they're getting extra data, and you're happy because you're controlling that zone and killing it when it's reasonable to kill. You're not waiting till it gets too big and the chemotherapy fails, right? I mean, we used to see that all the time with colorectal, right? But now it's kind of a team-based approach, you know?
Absolutely. Well, that's a benefit of multidisciplinary care, but also you're allowing that patient to stay on the same line of therapy, right? And they're not progressing on a line, on second line systemic therapy, then going to third line. You are, going after the oligoprogressive disease, and then hopefully keeping them on second line therapy and something that's keeping the rest of the disease at bay. So that's a win-win for the patient, especially if they're tolerating that particular line, and they may not tolerate a different line, right? So
yeah, the thing is though that everything that trumps is biology, right? You can be the best interventional radiologist in the world, and if there's an aggressive pathology, you're not going to help them. They usually find you and it's an oligoprogression, and it makes sense. And and if it's the first scan that shows metastatic lesions, I don't jump in. I said, okay, well, let's just do another 3-month scan. And oftentimes it's then 30. But if it's still 3, then we'll go in and we'll make a plan.
What's a biologic tested time, right? Makes a tremendous amount of sense. Fantastic. Okay, that's great points. All right, we talked a little bit about moving your RF needle around and getting temperatures in different areas and sculpting an ablation zone. Ablation confirmation software has a little bit of a buzz after the COVERALL trial out of MD Anderson. Do we need ablation confirmation in the bone?
That's a very good question. I never actually thought if we needed that or not. It's easier to ablate bone than other organs. So I've always felt that if your temperatures look good and your planning was good and you accomplished your plan, the goal is palliation, right? Not cure, but palliation. So confirmation is not as important as, say, in the liver when you have a colorectal net that you want to kill completely.
Yeah, it's an interesting one. I wonder, you are obviously an expert in this space. So for you to move a needle around and sculpt an ablation zone in a lesion with a tight adjacent margin or something like that is different than, let's say, I was coming out of fellowship and trying to do the same thing. So does something like that help democratize the bone ablation space a little bit? I don't know. Maybe that's kind of where my thoughts are. But to your point, I think we have some of the tools, and it is about what the goals of the therapy are.
Right. Well, you may want to do MR or PET in a short-term follow-up, but not necessarily do a verification at the same day, because I don't know if you're going to be able to see what you're looking for.
Yeah.
Unless you do an MR.
Yeah. Sure. Okay. So we talked a little bit about RF. RF obviously is still very relevant. The old notion is that the cortical surface of the bone, assuming that it's intact, will kind of insulate that heat from going outside the bone. Is that something that you believe, or is that an antiquated notion at this point?
Back in the day, I was doing research on ablation in the spine, and it was a pig model, and we were measuring temperatures adjacent to the vertebral body and in the spinal canal. And it turns out that, the pulsation of breathing in the spinal fluid actually helps reduce the temperature in the spinal canal. And I've done a fair amount of osteoma ablations in the pedicle without any intervention other than, just making sure my needle's in the right spot because of the pulsations of the CSF. There was a guy named Jonathan Lewin who was at Hopkins, and he did an MR-based model with pig and showed that you can actually heat into the nerves. But clinically, I've never seen that, having treated quite a few patients who've had spinal disease that I've gone on and ablated. And I think in practice, we don't see a lot of complications from a spine ablation. Do you agree with me there?
Yeah, I wonder sometimes if the cortical surface is not intact and somebody's a little bit overzealous, could you get into trouble? I
Absolutely.
think,
you have to worry about that.
Yeah.
But when you have an intact cortex, it does have an insulative effect.
For sure. Now, I wonder with the more powerful generators, as you were alluding to with the Cambridge interventions, is that a little bit more powerful to broach beyond the cortex? I don't know the answer to that.
The answer is probably yes. So it's all about your algorithms, Heat for 30 seconds, shut off, look at the temperature, and you're much more careful at what you're doing.
Yeah. Do you think we'll ever get to a point where we can reliably predict microwave ablation of the bone? I know a lot of people tend to stay away from microwave in the bone. Will we see that in our future, or are we there now?
Oh, I use microwave in bone a lot. I don't have an issue with microwave and bone. What particularly was the issue? Was it?
Just power, and again, being a little bit overzealous and broaching behind that bony cortex, where RF may be a little bit safer.
Right.
Kind of the genesis of the question. But again, maybe that's an antiquated notion. That's why I ask it.
Yeah. I mean, you can always use a thermocouple if you're worried, right? And most of the systems have thermocouples that you can use. And so you can monitor the temperature to make sure that the critical structure is not damaged.
Well, and there's so much of an art, as you've alluded to numerous times already today, just in shaping an ablation zone and not just parking a probe and burning to a specified amount of time, right?
Right. It's like cooking, right? I mean, you don't just set it and forget it. It's different.
That's a great analogy. Okay. How about sclerotic lesions versus lytic lesions? Do you change your algorithm or the device you use depending on, if you have a prostate met that you're going after versus, an RCC met?
Yeah. I mean, there's this notion that you can't ablate sclerotic lesions. Well, that isn't true. And if you look at the multi-center trials, you'll see that there are patients that have sclerotic lesions as part of the patient population. And the thing is, when you have a sclerotic lesion that's painful, you can imagine the endosteal pressure of that bone, right? And as soon as you drill a hole into that bone, it's almost like you're releasing that pressure. And I think there's a case that I actually gave you to illustrate. Patient had enormous pain in two areas, and we basically drilled in, we ablated, not the whole tumor, just an area of the tumor. And they had incredible reduction in pain. So it's not all of the bone that's creating pain, just part of it. And if you can release it, intraosseous pressure, you can relieve those painful lesions.
Okay, got it.
So it's really breast and prostate. Occasionally you'll get the sclerotic lung from a lung met.
And then any concerns with the lytic lesions like myeloma? We're starting to get more and more data there as well. I've not personally had bad experiences there, but what are your thoughts?
Well, myeloma, obviously, if it's a plasmacytoma and it's destroying a spine, if you can help the neurosurgeons, but a lot of those are surgical cases if they need to be strengthened with rodding and decortication. But as far as I'm concerned, it's a systemic disease primarily, and there's a lot more treatment options. So I would only get involved if you had a lesion that didn't respond to the traditional therapies plus radiation. Then I would probably get involved. But I don't see myself as a primary user in that indication.
But I think in that oligoprogressive type situation, right, you have a single lesion that is painful and, again, lumbar spine, just as for the sake of an example, no hesitation to ablate thermally and then cement.
Correct.
I assume. Okay.
Correct.
All right. That's helpful. I love this. We're playing Mythbusters a little bit here, and debunking some of these old ideologies. So it's great.
Sure.
Okay, how about superficial lesions? Obviously, I know you treat them. What are your techniques to protect the skin in superficial structures?
Sure. Well, with cryo, I have a microwave oven and I heat up bags of saline and we make sure that they're not too hot and we basically cover them in a sterile glove and I place them on the patient's skin and I actually have my CT fluoro image and I know exactly where the cooling is coming close to the skin. And I'll also puff up the dermis with fluid. So it's a hydrodissection to create a bigger barrier to reduce the chance of frostbite. Plus, I have the warm glove in a sterile bag sitting right there.
Yeah. Great point. I find that kind of hydrodissecting the skin, it tends to dissipate over time. So I just tend to leave a needle in there and just add more slowly, personally. But I struggle to see the ice ball in fat. I don't know if it's just...
Sometimes it's problematic. Absolutely.
And so sometimes that's where the fluid, I think, can help a little bit as well.
But, you can tell when it's frozen just by palpation. So you're getting close.
Good point.
You monitor
or ultrasound for that matter.
Right. So remember, we have all the different power settings on our cryo unit, right? We don't have to go to 100%. So if we have the needle that's closest to the skin, we know it won't grow if we go down to 75%. It'll stay there. So you can kind of cease and desist at that level by changing the power on the cryo system.
Okay. So your kind of a stable and steady setting is 75%. I tend to turn it down, to like 50-ish, but it's good to know that you have success with that. I appreciate that tidbit. Okay. So let's talk about some other data. The Motion trial, OPuS 1, Motion was more peripheral bony lesions. OPuS 1 was more spine. Both came out in the last several years. Both showed good benefit. One with cryo, Motion was cryo, I think, and then OPuS 1 was RF. Please correct me if I'm wrong.
No, that's correct.
Both showed quality of life indices improved, opiate use decreased. It was interesting that there is just a baseline non-responder rate and a percentage of patients that do have pain recurrence over time. No therapy is perfect, right? I think in IR, we think everything will work every time, and that's not reality. So how do we discuss that? How do we explain that? What are your thoughts?
Well, if you look at the OPuS 1 trial, like 97% of them also got glue, right? And there was no mention of the size in that study. So we have no idea what the size range was and whether that created a poor responder if it was a bigger lesion. So there was no correlation with size. It was basically, almost everybody got glue and some did okay and some didn't. I was wondering if any of them were involving the basivertebral nerve, because obviously the whole basivertebral nerve ablation for painful spine disease has been successful, right? The whole relievant system. And are we doing some spinal nerve ablations while we're killing the tumor?
Sure.
And we're getting a response. The other thing is there was no separation of who got glue and who didn't. It was just pretty much everybody got glue and everybody got ablation. So,
and by glue, you mean cement, right?
Yeah, cement. Yeah, so I'm sorry using a vernacular.
It's okay.
So like to do with the patients,
Yeah.
It's more of a glue than a cement.
Yeah. I gotcha.
When I think of cement, I think of concrete, but whatever. So there was that was not randomized. That was like real time study at a hospital. What do they call it? Real something study. Real life studies.
Yeah.
So there was no control group. So we can't really say why it worked. Was it because of the glue? Was it because of the RF, or you needed both? So that would have been nice, but to do that requires more money, more patience, and randomization. It becomes a lot more difficult to do. The motion trial was really good because they had a little bit more parameters. We knew the size, and all these trials obviously are sick patients who are stage 4 metastatic disease. So you do have 30% fallout because they die during the actual accrual of data. And I had the same thing with our Akron study. And you really have to have the good statisticians who can come in and kind of grind that data to come up with some meaningful ideas as to was this successful or not. And you can say there's, statistics and lying and statistics or whatever the expression is. There's some creative statistics that have to be done in those trials.
Sure. Yeah.
So the motion trial was a good trial, obviously, and I like to think that my work was kind of the first generation of all that stuff, because Matt Karlstrom and I, we did a cryo trial together, and then I did the bone trial through Akron. So those were 2 trials that were completed showing efficacy before these other trials. And you say, well, why did those other trials get done? Well, they did get done because industry wanted an indication, right? So they wanted to spend the money so that they could make money. But we already knew they worked.
Yeah, absolutely. And then we have good data for RF and cryo at this point. I think the challenge is to remind, again, patients that not everything works every time. And there is a non-responder incidence. And that's sometimes not what patients want to hear, but we have to be open and honest in these conversations.
Right.
All right. We talked a little bit about external beam before, and your thoughts on ablating before external beam. It's not insignificant in my practice that I get a referral that's already been radiated. The lesion has already been radiated. So concerns there, how do you approach those lesions? Any nuances?
Well, I think you have to form a team with your radiation oncologist. And I was lucky to do that when I was at Rhode Island Hospital. The rad oncs were very receptive to what I was doing, and we did a lot of combination work and published it. And they saw the real value behind it. You can do some retrospective data on these patients that already got radiation and do the ablation, and they actually do better than ones that didn't have radiation. And we looked at that in chest wall ablation. We presented that many years and published that. And if you had radiation within 3 months of the ablation, they did much better. So there is kind of a combination approach, and biologically it makes sense, right?
Yeah.
If you're killing the majority of the tumor that's in the hypoxic area, you're more likely to have better outcomes from the radiation. So if the radiation does consolidation and kills the tumor in the surrounding area that has more oxygen, then you hit it in the central portion with RF or microwave or cryo, you're going to get a better kill zone. So the question is who goes first? And I like it for us to go first.
Sure.
Because it's just, I think it's easier.
Yeah, I've had many post-SBRT spine, referrals for a new fracture, worsening fracture, or residual pain. And when you get 6 months down the road, they can be really tough to drill into. So yeah, I wholeheartedly agree, but just not the real world practice, unfortunately, right?
Right. Well, you got to be the voice of reason at the tumor board, and you say, hey, listen, you guys have, 15, 20% fracture in the spine after SBRT. We need to glue those patients before you radiate them.
And it's not stopping them from radiating them. It's
right.
Just complementing the therapy, right? And I think
Absolutely.
that is a great conversation to have. Totally agree. And so that brings us to the Tribute trial, which is the SIO-sponsored combination percutaneous ablation palliative radiation trial in high-risk lesions. So tell us, what do you consider a high-risk lesion?
Oh, obviously weight-bearing, something that is really close to the spine. It's going to lead to potential paralysis or spinal dysfunction. Something that is chest wall is going to grow out of the chest wall and become a bigger problem. Something that's getting close to a major nerve, and you want to, prevent that from creating a future problem with paralysis or pain. Those would be what I would think you want to do combo procedures on if you had a big tumor. Because if you fail, you're going to end up with a problem.
Yeah, absolutely. Yeah, and we talked about the kind of the interplay between the two therapies, but your points are very valid. Finding ways to play what I like to say nicely in the sandbox, if you will.
Right.
It's just there's a lot of animosity. We had the editorial that came out, I think last week, very anti-Y90, very pro-SBRT in the liver. And it's in my view, it's unnecessary. I think finding ways to work together only benefits the patients. And I do. I have very close working relationships with my radiation oncologists at my site, both in the liver and in the lung and in the bone. That's paid, I think, a lot of dividends for our patients. Any recommendations on how to do that for the public?
Well, we used to be one, right? Back in the 70s, radiology included treatment as well as diagnostic. And then we split apart. And then, of course, innovation occurred. So now we have all these image-guided procedures that the traditional radiology side has done. And now that's kind of creeping into the space of the radiation oncology. As I said during my annual oration at RSNA in 2013, we need to come together.
Yeah.
We need to join forces and work together as teams. Why are we putting the patient at risk just because of money? And we think our system is better, when clearly, if we work together, we're going to have the best outcomes overall, right? And if the department is the same, well, high tide floats all boats. So I think we really have to do that versus this siloing mentality that, no, we're the best, we have the best local control, it's minimally invasive. But unfortunately, they don't have a lot of data comparing what they do head to head with us. There's no randomized data. There really isn't. I did the trial in lung with early stage medically inoperable. Bob Timmerman did a trial there. And basically the 2-year survival is the same, right?
Yep.
One's an outpatient Band-Aid procedure. One is a non-Band-Aid procedure, but it's, 2 to 4 weeks over, at the radiation oncology. Yeah. So it's
great point.
There's a lot of synergy. And I love the fact that they're trying to do this trial again. Matt Karlstrom tried to do this trial with the Mayo Clinic. I don't know if you remember that 10 years ago, unable to enroll patients because the rad oncs didn't want to play in the sandbox, even though they said they would. And it's interesting, Jim Urbanek, he was the one who was trying to get this because Tom DiPetrillo and I were doing this combo therapy and we were presenting data and we were trying to get people to do it. And Jim thought it was great. And he's still around, and hopefully he can get this trial through by getting his colleagues in the rad onc side to participate. I'm hopeful.
Here's to crossing our fingers, right? I think only good things to come when if we're able to accomplish something like that. So great points, and thank you for sharing that. Damian, that was really a wonderful discussion. Thank you for all of those tidbits and just sharing that wealth of knowledge. Let's do some cases. It's always we're IRs, we're radiologists, and seeing visual images always resonates. It's always a fun part of these types of discussions. So let's start with chest wall recurrence. Thank you for sharing these in advance, by the way.
Sure. So we can see on the upper left this large soft tissue mass expanding a rib. And this was the patient's prime reason for looking for treatment is because of this. He had other disease, which I'm not going to show, but this was a nice case showing how you really want to concentrate the bone-tumor interface with your treatment. And we used the 3, I'm trying to remember the vendor, but we'll just say cryoprobes, 3 of the more powerful cryoprobes that were 5 centimeters in length as far as the active portion. And we placed them in the position of the mass, and we freeze, thaw, freeze. And I like to do the typical 10-minute freeze, 8-minute thaw, 10-minute refreeze. And then we scan after each freeze. And obviously the second freeze cycle, we tend to see a much larger ablation zone. But when you look at the last freeze, you can see I did a pullback and a refreeze. We had significant coverage of the bone-tumor interface. And at that point, the final image, which is the top right, we can see that the bone-tumor interface was covered pretty much completely where the ribs start to be destroyed. And that's really where the pain is going to come from. So it's just a nice case, not a very difficult case because you've got a big chest wall with lots of fat there, so we don't have to worry about frostbite here, and we don't have any other really critical structures to worry about.
Great, really, really fantastic case. Again, highlighting the importance of covering that bone tumor interface and not worrying about the entirety of the lesion. I do have to ask, in the thaw cycle, and I find that everybody that I ask, there's no consensus. Do you active thaw? Do you passive thaw? Do you do both?
Well, to me, active thaw just keeps the probe in the right position. I have to do an active thaw because the central part of the freeze is lethal ice.
Got it. Okay, that's great to know. I think the one place that I like to do just a short active thaw is in the lung with cryo, just so I can kind of get a better sense of my ice ball coverage. That's helpful to know.
Plus you also get the weeping of the capillary damage, which helps couple the energy to the tissue. So you get a better freeze.
Yeah, great point. Okay, so this is a breast cancer patient. I'll let you take it away.
Yeah, so this is a woman who has multifocal metastatic disease, breast cancer. She was a nurse at the hospital, and she had unremitting pain of her left chest wall and her right pelvis. And you can see she also has a met in her lumbar spine, but that was asymptomatic. So I was asked to ablate her, and you can see the extension of the disease outside the lung and the left apex.
Yeah.
And obviously you can see a weight-bearing bone, posterior acetabulum, with pretty easy places to get to. So if you can go to the next slide, I used RF in this instance, and I believe this was the bipolar RF system. And I was able to do multiple overlapping ablations, again, covering the bone tumor interface. And we can see that covered in the chest wall. She actually had another one involving the transverse process of the lumbar spine. So we went after that. And then the third one we did in the pelvis. And then you can see the cementoplasty that was done at the end of the case. And we can go up one more slide.
Sure.
And we can see the placement of the cement there. And this woman actually bounced off the table and her pain was completely gone and the tears were stringing down her face. Everybody who knew her in the hospital was congratulating me on helping this woman. And, I had no idea how powerful the ablation could be. And all I did was take the areas that she hurt, and I covered the bone tumor interface, and then I strengthened the weight-bearing portion. That was all done in one procedure.
That's amazing. I wanna ask a couple questions about this. I mean, so this pelvic lesion, these periacetabular lesions, what do you do if the acetabular roof is not intact?
I still glue it.
You still, okay, all right. And just obviously any glue into the joint space is bad, but as long as you can control it and keep it within the lytic lesion, even though there's no cortex there, you're comfortable with that.
Yeah, you get a synovial irritation, but if you keep them quiet, for the 2 hours afterwards, you're going to keep it from being too much. Obviously you don't want them weight bearing before they get fully strengthened.
Sure. I gotcha. Okay, very cool. And then, these more, I guess, the transverse process lesions and more central lesions that are adjacent to the vertebral body, I assume the intercostal nerve is kind of eroded away to begin with, but any concerns on, if it's still, and it's a small lesion, it's still in place and kind of having a Sunderland grade 1 injury of the intercostal nerve and some allodynia, or how do you deal with those kind of situations?
Well, those patients will definitely let you know that there's something awry. So they'll have a radiating pain, usually have numbness too in the front, and then they'll get the shooting pain during the recovery process. And, you can treat them with gabapentin, and they will get better if they live long enough. Because occasionally it happens when we're ablating near the chest wall for cure. So you'll sometimes see treating a kidney lesion, and then you'll get a paralysis of the abdominal wall and they think that they have a hernia, but the muscle is just lax because you've taken out the intercostal nerve there. So to me, I'm not worried so much of the nerve. I'm really more getting rid of the cancer pain.
Of course, absolutely. And just as a resource, for those of us that don't know our nerve anatomy as good as you do, what do you refer to to just try to understand the path of some of these nerves, maybe in the pelvis or around the shoulder, away from, intercostal area?
Well, obviously, the intercostal nerves, nobody's really worried about those too much. Obviously, the thoracic nerve, you can get a wing scapula if you take that out, which is...
You're talking about that top left image in particular?
Yeah. Which you can't avoid, obviously, in certain situations. And that's not a game changer, really, if somebody's got a painful metastatic lesion.
Yeah, it's a cosmetic issue, right?
Yeah, exactly. There was a great review article that was written by the Mayo Clinic about all the potential nerves that could be damaged with ablation. I think it was a radiographics article. And I always refer people to that article because they basically take every possible nerve that we could get in trouble with, and they have examples of it. It's great. It's great. So.
Absolutely. I also keep the Anatomy Atlas on my phone, and I reference it probably once a week for some reason, So great point. There's good stuff that's out there to help guide us. So that's really wonderful. Very cool. So this patient did well and had no pain, as you said. So fantastic. Okay.
So this is a patient who had sclerotic mets to the rib and to the spine. And I saw him in consult, and I was a little skeptical that I could help him, but there was such severe pinpoint pain, and nothing was really working, and his quality of life was horrible. And I said, this rib is expanded here. I said, I can drill into this rib, and I can ablate a portion of it. I don't know if it's going to work. And the same with the pedicle lesion on the next image. And I had done a patient as part of the Akron trial who had a painful spinal met that was sclerotic that had complete response. So I was willing to try this patient to see if the same would happen. And sure enough, it did. He had complete relief. And I only ablated a portion of the tumor, but I created an open conduit from the endosteum to the outside world. So I was wondering if it has something to do with pressure effects, or did I kill enough of the endosteal nerves to reduce his pain? Very unusual.
RF or cryo in this case?
This was RF.
This was RF. And I struggle with these cases, just like you alluded to. I've had some success. I've definitely not had success as well, and these can be very challenging. Well, I mean, just to access the bone can be challenging, right? That's probably half the battle.
Now, one of the trials had a couple of sclerotic lesions, and it was a cryo trial. And remember, with cryo, because of the probe size, you're going to have to cut the bone out first. Just make sure that your cryo probe isn't in there while you're cutting bone, because a couple people have done that and accidentally nicked the cryo probe and didn't realize it. And then when they activated the freeze cycle, you had that pressurized argon gas, which basically killed the patient immediately. Wow.
Got it. And you're talking about advancing the outer bony cutting needle with the cryoprobe already through it.
Right. No, next to it. So say you place one and you want to place another one.
Got it.
You cut all your holes first, then put your probes in second.
Yeah, that's a great point. When I'm using cryo in sclerotic bone, I'm also just drilling all the way through the bone to where I want the tip of my probe to be to begin with, and then pulling my bony needle back. So that's a great little tidbit. How do you feel about biopsying, just a soft tissue biopsying next to a cryo probe? Do you think there's still a risk there, or is that overstated? Well,
generally what I do is, I have the parallel needles.
Yeah.
And then I put my biopsy needle right in between, and it's a 1920 Temno, so I'm not worried about it.
Some space. Okay. Got it. So it's really the bony needles. And then what are you using from a bone access device? What do you prefer?
Well, I do on control.
Okay.
Because I think it's the most powerful.
Okay.
And it really is fast. And I just, tap it in initially with a hammer, and then I just take the stylet out and drill as far as I need to go. And then you get a beautiful coil, which you can send to pathology, and then you have access to do the ablation. Now, for vertebroplasty, I use the 13 gauge access needles.
Okay.
And, I tap those in and then just to get to where I want to go.
The uncontrolled needles.
No, those are those are the needles, the glue needles that
they come with
the kit.
Yeah, I gotcha.
They're 13 gauge access needles.
Yeah, I gotcha. I don't know of anybody that's using a bone drill in the spine. Obviously from a control aspect, we want to be able to control the depth of the needle, but I can't say that I'm opposed to it. I just have never tried. I don't know if you have.
I'll do a manual one. I'll use the Stryker bone cutting or the mini from the company out in Salt Lake City. What's the name of that company?
And manually drill versus a power drill?
Yeah, manually. Yeah, exactly.
Okay. Got it. Okay, I gotcha. Very, very, very cool case. So how did the patient do?
With this patient?
Yeah.
This patient did great. He had no pain at the end of this procedure. So, and I never saw him. I had one follow-up and he was doing great and he just went on and lived his life. He ended up dying of metastatic prostate cancer, but he never had any recurrent pain.
Yeah, gotcha. And just as an aside, and maybe this is a crazy question, do you ever consider cementing a rib that has a pathologic fracture?
No.
Okay. I assume not, but I thought I'd ask for the sake of discussion.
I've done the pubis.
Okay.
There's more movement in the pubis.
Sure. Makes sense. And then that was the FDG PET.
FDG PET showing that no activity in the area that I treated.
That's fantastic. Beautiful work. All right. One more case.
Yeah. So this is a guy who had solitary met from thyroid cancer, and you can see it, the lucent area in the right ilium, and you can see it's hot on PET. And I felt this was a great one to do microwave because of its kind of long shape, and there was a fair amount of good bone there. So you can see my microwave antenna after I cut an access hole. You can see as I'm cooking it, the low density changes. That's gas actually forming inside the bone.
Okay.
And then I did an MR.
Wow.
Showing the area of destruction. You can see beautiful gadolinium surrounding the area that we treated.
That's beautiful. Beautiful result.
And here he is at 6 months and then 26 months. So it was a complete local cure with microwave.
And then, I know we talked about this briefly earlier, but you're not just setting it to the manufacturer setting and then ablating. I assume you're shaping with microwave as well. What is your technique to shape a burn in there?
Well, you want to measure temperature. This particular device doesn't allow you to measure at the tip, but it measures at the shaft. And it's approximately 2 centimeters above the active portion of the microwave antenna. This is the new wave system. So you want to have, lethal temperatures in that area. And then I'm pointing at the area that I don't want to treat, right? I don't want to treat into the obturator area, and I don't want to treat in the iliac area. So I'm basically kind of protected. And what's behind me? Nothing really.
Yep.
There's just some fat and skin. So, and I'm nowhere near that. So it was a very safe area to treat with microwave.
Yeah, great point. And the general rule is always that the ablation zone is going to grow backwards along the probe, right? It's not going to grow forward as much.
Correct.
So
Correct.
That's a great point. Beautiful, beautiful case, and a microwave case nonetheless in the bone. So, well, Damian, I really appreciate it. That was really just a fantastic discussion today, and just a wealth of knowledge and insight from you. Thank you for taking the time. This has been a blast. I look forward to doing this again soon. And any final parting thoughts or comments?
The best thing I could tell you is to befriend your colleagues in cancer care. You're such an important part of the team, and everybody works in their own little silo, right? So you have to educate, and you educate with kindness, and you educate with collegiality. And if you do that, they will send you cases, and you can show them what you can do. And the next time a case comes up, they're going to be asking you for support and help.
Yep.
And it doesn't happen overnight. You got to be there and with a smile on your face. So you attract bees with honey.
Absolutely. 100%. I mean, that's so well said. And you have to play it cool, if you will, right? There are always going to be naysayers in the multidisciplinary setting, or there's not data for this, or you shouldn't be doing that, and et cetera. And you You got to play it cool and just let your work kind of show what you're able to do, let the outcomes show, and be available and affable and able, right? That old adage. So
exactly.
100% agree.
The 3 A's, yes.
The 3 A's. There you go.
Yep.
There you go. So, Damon, thank you again. This has been a wonderful discussion, and I look forward to doing this again with you.
I agree. I'd love to. Thank you so much.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.